There's a message from Priscilla about the opportunity to share information about flyers or registration links and resources you'd like to share. And I'm going to hand it now to Maritza Lara and Haley Mears to start us off with our partner announcements.
Thank you, Stephanie. Good morning, everyone. This is Maritza Lara, Population Health Director at the Health Improvement Partnership. A few weeks ago, during the annual board meeting, I shared with you that HIP and the Santa Cruz Workforce Development Board had established the Santa Cruz Health Workforce Council. Next slide. Some of the goals that I shared during this meeting is that we want to first get the right people on the bus for this council, and then conduct a robust health sector employer landscape mapping with healthcare players to inform the council's direction. Next slide. There are the two goals that I just spoke of. And today I want to introduce you to the newest hipster, Haley Mears. Haley joined the HIP family last week as HIP's Workforce Development Program Manager within the Population Health team. Haley, we're very lucky to have you, and I pass now the virtual bite to you.
Thank you, Maritza. I'm really excited to be here working with HIP. As Maritza mentioned, I just joined HIP last week. Prior to that, I was doing workforce development with the Monterey Bay Economic Partnership, which many of you may be familiar with. And that was serving the entire Monterey Bay region in all industries. And so I'm excited today to start focusing in on healthcare career pathways and working with HIP in Santa Cruz County. I'm a Santa Cruz native. I've lived here most of my life, and I went to Cabrillo College, got my AA there, and transferred to UC Santa Barbara, where I majored in sociology and theater arts, double majored. And then I went to San Jose State and got my master's in education counseling, and have been working in the workforce and career services world since then. Over 6 years at UC Santa Cruz as an academic advisor, and also doing job placement, career services, and internship coordination. And so I'm just really excited to be here working with you all and supporting the good work you're all doing in Santa Cruz County. That's it. And I'll hand it back over to Stephanie.
Thank you, Haley, and Maritza for the update. Just pausing to see if anybody had any questions or comments for Maritza and Haley.
I actually will just add one more comment here, is that we will send out in just a second a link that you can fill out. I see that there's some interest on the chat to join the council. And so just one more minute, I'll send a link. If you fill that out, you'll get updates of the council, an opportunity to join, and we definitely want you on the bus. As I said on the board meeting, it's going to be a lot of fun. We have a lot of really interesting people there, and I always give a shout out to Lara Marcus, because I know that in her previous life she had a job doing a bus orientation, and so whenever she's in the room, it's fun. Oh yes, Lara, tell us, encourage us, please.
Go for it. Yes, I encourage you.
Thank you. That's it.
Thank you. So now we have about 13 minutes, which is a healthy amount of time for any additional partner announcements. And so you can unmute yourself and speak up, or raise your hand and I'll monitor the participant list. Let's see if anybody has any partner announcements. I almost can't believe it. Like the December pre-holiday fatigue, or else we're so excited to hear the COVID update, we don't want to go. Let's see, give it one more minute. Check the chat. Okay. So just noting that the form for council interest for the Santa Cruz Health Workforce Council is in the chat. So if you're interested, please access that there. And we'll take this moment then to transition to Jen Herrera from the county, who's going to kick us off with the COVID-19 update and discussion.
Thank you. I'm going to go ahead and share my screen. Okay, so I'm just providing the usual COVID update. And can you hear me and see me okay? Or see the screen okay?
Yes.
Okay, thank you. So we typically start with a global view. This is a different chart than what we've typically shown. Typically, we show the Johns Hopkins dashboard. This is from the WHO weekly report on the global COVID-19 data trends. So globally this week, we've seen a case incidence plateau, and that's between the week of November 29th through December 5th, with over 4 million confirmed new cases reported, similar to the number reported in previous week's figures. However, new weekly deaths increased by about 10%. When we look by region internationally, the highest cases and death rates continue to be in the European and Americas region. And when you look at it by nation, the United States continues to have the highest number of new cases, with about a 30% increase over the past week. And again, this is from the World Health Organization. They develop a weekly report on their website, which I put the link here. Drilling down to the state, we continue to see increases in vaccinations. And we also see a bit of a plateau of cases. We've seen a general downward trend of deaths and a decrease in test positivity. So that's interesting, but it's not too far off from where we are locally. In general, we are seeing an increase of cases, although it's at a slower pace than what we saw previously last year. And you'll see that in the next couple slides. When we look at a region, everyone in our region is increasing in cases steadily. So Santa Cruz, compared to other counties, are pretty much in the same boat. And looking at our case numbers locally, we have over 21,000 total known cases of COVID-19, 620 of which are active cases, and we have had 224 deaths due to COVID-19. I believe we'll be posting a new death, so that will be 225 at the next dashboard update, which is typically Mondays and Thursdays, so that'll be updated today. You can see here by our epi curve, which is just for the time period of July through December. Excuse me. That we had a surge with Delta, and then it subsided, and now we're starting to see a steady rise in cases again. And then in terms of general demographics and transmission, that hasn't changed since I last presented at HIP Council. So transmission tends to be primarily person-to-person, community acquired, followed by household spread. So looking at our general trends, our effective reproductive number, which shows how fast COVID spreads in our community, this was surprising that our effective reproductive number is under 1. We were expecting it to be higher, over 1, but maybe it'll potentially rise in the coming weeks once, because we typically see a bump in cases about a couple of weeks after Thanksgiving. So this is interesting, and we just continue to keep a close eye on it, because we are expecting cases to steadily rise still through the winter months. And this is the average number of daily new COVID-19 cases in the last 14 days. So here you can see that our cases are still rising, but again, at a much slower rate than where we were in previous weeks. So we've only seen about a 10% difference in change, but it is still increasing. And then compared to last year, so you can see the yellow dots are where we are for this year, 2021. The red dots are kind of behind the yellow dots. Over here is where we were in last year. So a much slower spread than where we were last year. So this is good news, but it is something that we continue to be cautiously optimistic about. Test positivity rate, we have seen an increase in our test positivity rate by about 1% in the last week. However, we also experienced a drop in testing, so we're not sure if the drop in testing was influencing that number. Looking at hospitalizations, we're expecting a slight increase in hospitalizations, not by much, and that's the same with ICUs and with deaths as well. When we look at COVID cases by county region, here we have Mid, North, and South County represented by different colors. You can see that all the counties, North County does edge out the other counties, but not at a major disproportion. So this has stayed the same since the Delta surge, where we haven't really seen a huge disparity among the regions, but North County typically has more cases. This is state data. This is not local, but it is unvaccinated versus vaccinated data. So when we look at cases, hospitalizations, and deaths, the unvaccinated population is represented by that pink reddish line, and the vaccinated population is represented by the blue line. And you can see here that there's the unvaccinated population is far more at risk for getting COVID, being hospitalized for COVID, and dying from COVID. So moving on to some state guidances. This is just a list of all the new guidances from CDPH and CDC. And of note, there was a new therapeutic, an oral antiviral. I do not know how to pronounce it correctly, but it's molnupiravir. And so our county will start to have that available soon. Of note, it's the monoclonal antibodies are still a preferred method of therapeutics for people to treat people who have COVID. But this is a less invasive therapeutic, and it's good that it'll be available. So Omicron variant is a variant of concern as assigned by the World Health Organization on November 26th. Omicron, as of this week, has been reported in about 57 countries across all of the WHO regions. And while most of these cases identified in the countries are currently travel related, this may change as more information becomes available. I do want to note that Delta still persists as the most dominant variant worldwide, accounting for about 99% of specimens collected. Omicron accounts for about 0.1%. So it's still fairly contained. We're not seeing widespread spread. And again, a lot of the cases that we're seeing internationally are more travel related. We anticipate that this will change, but just wanted to make sure everyone was aware about that. There have been multiple cases detected in the United States, and the first one was actually discovered here in San Francisco on December 1st. And then CDPH and CDC have developed some new travel recommendations for people who are traveling abroad. So going into our local response, there have been over 438,000 COVID-19 vaccines administered in the county with boosters and primary series. And this month actually marks our Vaxiversary. It is the 1-year anniversary of us as a community distributing vaccines. And what a wild ride it has been. So I just want to take this moment to thank all of you, because we are one of the top performing vaccination counties, and one of the best vaccination rates in the state. And not only that, but we've been able to show equal distribution of our vaccines across our regions. And we could have only done that because we have worked together so closely on this. So thank you all. So in addition to vaccines, we do have a local face covering order. It does not have an end date. We will be evaluating just case rates, the situation, case rates, hospitalizations, the usual, to determine when that order will be lifted. It's flu season, so get your flu shot. And then lastly, we have our vaccine stripe team that is providing vaccination to congregate care facilities throughout November and December. One of the other focuses, which has always been a focus, is supporting the healthcare system through the COVID response. Healthcare sustainability continues to be a primary component of our response. Our DOC, EMS program, and emergency preparedness program continue to track hospital census on a daily basis. We do our modeling, which I showed earlier. We have our healthcare coalition, which many of you participate on, and we also hold some special calls for SNF partners and acute care facilities. And it's really in the effort to ensure we have capacity. So while we are flattening the curve and trying to delay a peak of a surge, we're also working with our healthcare system to ensure that that baseline healthcare system capacity doesn't drop too far. So with Watsonville Community Hospital, hearing that there's a potential closure, we did gather our partners. Some of you were involved with our initial call to to provide reassurance that we have plans to address that if it did happen. Thankfully, it did not happen, and there's a plan for the hospital to stay operational through March, which is awesome. But it did highlight an opportunity for us to do more assessment of our healthcare system and also to update some of our evacuation plans. So I think, so we're going to continue moving forward with that. And I just wanted to give you a heads up, as many of you will be involved with that planning. So testing opportunities. We are maintaining the OptumServe mobile testing bus 7 days a week. It is available in Santa Cruz at the Depot Freight building, Monday through Friday, 8 to 4, as well as Felton at the Mountain Resource Center from 10 to 6. We are still maintaining a fixed location at Ramsey Park, and that is Wednesday through Sunday, 7 a.m. to 6:45 p.m. The location at Ramsey Park will likely change sometime in January. So we are still committed to keeping a community testing site over in the Watsonville area. But our contract with the city is up, and we're looking at another location, and we will keep you posted. Vaccine expanded opportunities. So there has been an increase of demand for vaccinations, specifically boosters. So we did increase our hours over at the Watsonville Vaccine Center. It continues to be open Thursday through Sunday, but we've expanded our hours to 9:30 a.m. to 5 p.m. Appointments are preferred, but we have walk-ins available. And we are providing all products, Moderna, Pfizer, Johnson & Johnson, as well as pediatric additional doses and boosters. We also have our team going to Vax the Valley at Felton Community Hall. So this is a pop-up vaccine clinic over in Felton, and that is Wednesdays in December from 1 p.m. to 7 p.m. Again, appointments preferred. All products and types of vaccines are provided for COVID, and special thanks to the Rotary Club of San Lorenzo Valley and local businesses who supported the effort. Going into some vaccine data. So over 200,000 of our total county population has been vaccinated with at least one dose, which is about 75% of our total county population. And we did update our demographics page to include the 5 to 11-year-olds. Of note, you'll see that there's no gray bar behind the blue bar. So there's no, this is not a rate or a percentage, it's just a number. And the reason for that is we're doing some dashboard updates to align our denominator with the states, and that's still in transition. But in the meantime, we still wanted to ensure the public was aware of how many kids were getting vaccinated. So right now, over 4,000 children have been vaccinated. I think the number is actually much higher. We have seen some data delays, so it may be closer to about 6,000 or 7,000 children. Looking at boosters, so the lines represent different age groups. We have 16% of our 18 to 49-year-old population who've received a booster, and this is among the population who has been fully vaccinated. 33% among 50 to 64-year-old population, and 54% of the 65 and up population. So we have a ways to go, but we have continued to see a demand for boosters at our vaccine clinics. The state does have 2 vaccine equity goals for COVID-19, and goal 1 is ensuring 75% of 12 and up population across all race and ethnicities have received at least 1 dose of COVID vaccine. And goal 2 is decreasing inequities by place and by insurance. So I just wanted to show the next couple of slides on what that looks like. So this is from the state's dashboard. It represents goal 1, ensuring 75% of 12 and up populations have across race and ethnicities have received at least 1 dose of COVID-19 vaccine. This data has never been the cleanest. There's an over-representation, I think, of like multi-race and some of the other categories that don't quite make sense when we've looked at our demographic data here locally. But it is a place for us to start, and it is data for us to kind of think about when we're thinking about vaccinations across race and ethnicity. And then goal 2, which is decreasing inequities by place and insurance type. So the graphics here are really it's the same data telling, it's the same data, but it's a different visualization, and it's Santa Cruz County's vaccination status by the Healthy Places Index. It's showing that we continue to have pretty equal vaccination rates across our regions. And I put on the top right here, I put this saying that equitable efforts for equal outcomes, because that's really what we're trying to do. When we're trying to, by recognizing that certain regions and populations in our community historically have disproportionate access to care and resources, like we know all of that. And so what we did as a community, not just public health, we really focused our efforts on supporting the regions where we know there was historic disproportionate or historic inequities, in order to ensure that we would have equal outcomes in terms of vaccination. And in the meantime, we recognize that those root causes that causes inequities are something that we're going to continue to have to work on, like racism and poverty, access to care. And then it's a lot of text, but I did want to just mention that DHCS is still comparing the Medi-Cal member vaccination status versus the counties. And so for Santa Cruz County, they note as of November 15th, with about 76% of total residents vaccinated, only 57% of our Medi-Cal beneficiaries are vaccinated. And that is that type of gap is something that we continue to see statewide, but there are a lot of efforts to help close that gap. And my last slide is just a reminder to get vaccinated, wear a mask in group settings, stay home if you're sick, and I hope that everyone has a happy holidays. All right, and that concludes my presentation.
Hey, thank you, Jen. We have time if there are questions or comments that people would like to share about the COVID-19 update. And so please raise your hand or unmute yourself and go ahead and speak. Giving people a moment. Well, as people consider whether they want to further the discussion, just thank you, Jen, for all the data. I was just reflecting on the presentation as you were going through how in command of the data and the response and the activities locally to ensure that our fellow community members are safe. You are, and the way that you're talking about things, just in terms of referencing back to patterns that you've observed or that the county has observed in the disease progression and the response. I'm just struck by how this has become sort of what we all are working in now, and with the county's leadership, just in terms of the response. And so really grateful for the work that you and your team in the county have done over the past couple of years to help lead us through this, and all of the efforts of the county partners to really ensure that we have a strong response locally. And just wanting to offer some recognition and celebration of that, because I think we've been in this really challenging time for so long. And I feel like we're more in a responsive mode now as a reactive mode. It's just sort of part of what we do. And it's an interesting reflection and place to be in, but I think that's a huge part of what the county has contributed and has led us all through. So just thank you for that. And for the information and keeping us all on the same page with how it's going. So I'll pause and see if there's any other reflections or questions, comments. Okay, thank you, Jen. I think we're going to move now to Kathy Conway. So Kathy, I'll turn it over to you.
Great, thanks, Stephanie. And good morning, everyone. I think it was maybe 2.5 or 3 years ago that we came to HIP to present on the End of Life Option Act. And there have been some updates to the law, and wanted to present those this morning. And also one of the updates is a requirement that healthcare entities throughout Santa Cruz County and throughout the state have to take action on. So I wanted to make sure people knew about that as well. Next slide, Anais. Thank you. So what I'm going to present this morning is an overview of the End of Life Option Act, so everyone is aware of the actual law, what the current process is. I want to share some statewide stats so we can understand better who chooses the End of Life Option Act. I'll share some local numbers of Hospice of Santa Cruz County and how we've supported patients choosing this in our community. Then we'll go into the changes in the law and the requirements for healthcare entities. So the End of Life Option Act, that is the name of the law. It became law on June 9th in 2016. And what that does is allow terminally ill adults living in California to obtain and self-administer an aid in dying medication. And we were the 5th state to adopt what's also, you'll hear people call it medical aid in dying, or MAID. That's kind of the global name for it. The End of Life Option Act is the California law. MAID is now legal in 10 states, and also in Washington, DC. So to be able to obtain an End of Life Option Act prescription to receive the drug in the state of California, a patient must be 18 years or older, and they must be a resident of California. They must have a terminal illness with a 6-month or less prognosis. They have to have the capacity to make their own medical decisions and not have impaired judgment due to mental disorder. And then they have to have the ability to physically or mentally take the medication at the time that they want to take it. So this isn't something that can be written into an advance directive or other healthcare documents. Healthcare agents or surrogates can't make this choice for anyone else. Even if they know that the patient would have wanted this, it has to be done by the patient, and the patient has to self-administer. So the current process is that when a patient is interested in End of Life Option Act, they need to make 2 oral requests. Those requests have to be 15 days apart, and they make these directly to their physician. And then there's an additional request that has to be made in writing. And the writing, there's a specific form that must be filled out and witnessed and signed. And then the patient sees 2 physicians, their attending physician, or the attending physician is the physician who will be prescribing the medication. And then there has to be a second physician, a consulting physician, who can confirm the patient's diagnosis, the prognosis, and their ability to make medical decisions. If either of these doctors thinks that the patient might not be mentally fit to make this decision, the patient must also see a mental health specialist, and that person must also sign off on this. So in that meeting with the physician, here's a list of what needs to be discussed. I think this list came about to really make sure that the patient choosing this option has really thought through this. Obviously, once somebody ingests, there's no going back on this decision. And so they really want to make sure that the person has made this decision clearly. So they discuss realistic alternatives to taking the drug, letting the patient know that along with going through the process of obtaining a prescription, they can make a decision at any time not to continue the process or not to take the drug once they have the prescription filled. They can choose to notify and share with their family that they're making this decision, but they do not have to. They can be on hospice care and we can support them in making that decision, but they do not have to tell us that they are choosing this. And the most important thing is that they know that they can change their mind at any time. So this is some state data. This is from the California Department of Health and their 2020 report. And of the 435 individuals who died in California throughout the state using the End of Life Option Act, this gives you a little idea of who they are. Median age of 75, they're white, male and female is pretty even. They are college educated. 86% of them were receiving hospice or palliative care when they made this decision. And most of them informed their family that they were planning to ingest. I think what you see in this picture is we usually see this as somebody who feels very strongly about making their own decisions and having control of their life throughout the end of their life. Here's some information about the disease that is the underlying disease. I should say also that when somebody chooses the End of Life Option Act and does ingest and dies, on their death certificate, it would be their underlying disease that is listed as the cause of death, not the End of Life Option Act. This is very important for patients and their families for a number of reasons, but including insurance purposes. And that, this is a choice that they've made because of this disease that they have. So that's what's listed on the death certificate. So here's some information about Hospice of Santa Cruz County and the patients that we've served. In this last close to a year, I pulled the information from last January up till last week. We had 92 patients who inquired about the End of Life Option Act. 27 of them died from ingestion. So you'll see a lot of people ask about it, and our staff is trained to talk about their options with them, but very much fewer ingest. A number of patients didn't proceed after the initial inquiry. A number of patients, 6 patients received the prescription, but died without ingesting. And we have patients that are somewhere in the process. So the number of patients that we served during this time it was 914 patients. So this falls around 2%, 2.5%. Statewide, we see the numbers of patients choosing this between 1% and 2% of hospice populations. Our goal at Hospice of Santa Cruz County is to support any decision a patient makes related to End of Life Option Act. So we are going to ensure that we are managing their symptoms and supporting them emotionally, but we support, we educate and support. We're an educate and support hospice when it comes to End of Life Option Act. Our physicians can be the consulting physician, which means our physicians are not prescribing the medication, but they can be the second physician. Many physicians don't know all the rules and the regulations around the End of Life Option Act. We can point physicians in the right place to get the information that they need, because it is the attending physicians and the patient's responsibility to fulfill the requirements of the law. We have a lot of experience in this, so we can support with that, but it really is the attending physicians responsible. So our staff has been educated, and we do regular education on a yearly basis. And when new staff are coming on, it's part of their orientation. We've been training our folks to talk about the End of Life Option Act with patients without judgment. There was a study back in Washington when Washington first started their medical aid in dying law. And one of the complaints from patients who were in hospice and receiving medical aid in dying is that they felt judged by their hospice worker. And we really took that to heart and started to look at that, and noticing how something as simple as when somebody would share perhaps that they were interested in pursuing this, and if our staff said you are, that could feel like a judgment. And so we really looked at our language of receiving that, thanking them for sharing that, asking if we can hear more about what their thinking is about that, and giving them the information that they have. We want to make sure that they have all the information they can to make the decision, but we also want to understand if there's anything that we can do, around pain and symptoms that would ease them, and perhaps they wouldn't choose the option, right? So because there's so many reasons people choose this, it's really usually not about either pain or symptom. It's about wanting to have control over their own life. We do allow our staff to be present at ingestion, and that is if it's requested by the patient. So here are the list of the changes, and the next few slides will go into the changes a little bit more. But the biggest change is that the mandatory minimum wait between the first and second oral request has been reduced from 15 days to 48 hours. So that's a huge thing. And that really came from the complaints that we were hearing on a national level, on a state level, around people not having access to this because of the waiting period. Healthcare systems and hospices must post, starting in January, their End of Life Option Act policy on their website. So that does impact, I know, a number of people on this call. There was something called a final attestation form that the patient needed to sign right before they ingested. That has been eliminated. This next one is important. If a patient makes a request for medical aid in dying and their doctor cannot support them or chooses not to support them, that doctor is required to tell the patient that. The doctor is required to document that request in the patient's medical record and to transfer the patient's medical record upon request. So that is a change in the law that we didn't see before. And then that the End of Life Option Act meds can be ingested within healthcare facilities. And that wasn't clear in the last version of the law. So this all came about because this law was going to sunset. And so in February 2021, there were hearings that were held to really look at this. And it was Senator Susan Eggman who wanted to bring this forward, mostly because of the amount of complaints. I think last time we presented on the End of Life Option Act, we did bring a community member who was a volunteer with Compassion and Choices, who spoke so from the heart about experience she had heard from people wanting this option and not being able to find a doctor who could help them with it, or were not able to work within those 15 days. The studies found that between a third and a quarter of the patients couldn't wait the 15 days. And that means when they were wanting to choose this, they were either not going to be alive in 15 days, or what was more alarming is that they would lose capacity. So they would not be able to self-administer. So there would be something that they would want to do, they felt they had the legal right to do, and then couldn't do. So this change in that 15-day waiting period will help with that. Dr. Lonnie Shovelson is well known in our state as the physician who, for the first, I think, 3 years of this law, really supported many patients choosing this option. And he recently just did a webinar around this where there were physicians talking about what it meant to have that change. And they talked about the 48 hours really being a floor, not a ceiling. They don't want, like so many things in our society these days, you know, we send an email, we expect immediate response for patients who want to take advantage of this law and want immediate response. They're not feeling that that shouldn't be the case for everyone, right? They're looking at this as an option, not a requirement. What happens often is that because there are so few doctors who will prescribe this, some of the doctors who do prescribe are meeting the patient for the first time. It's a very difficult decision for them to write a prescription in a 48-hour time period and not knowing the patient. And so there is a desire for that to really be more of an option and not a requirement, but it is in the law now. So the 3 requests still stand, 2 oral and 1 written. The first request, so this is an interesting part of the new law. While the doctor, so a patient can make a request to their attending physician, to whoever their physician is. And while the doctor may say that they don't support End-of-Life Option Act, or they can't support End-of-Life Option Act because of their healthcare system, they must document that as the first request in the EMR. There is discussion on whether this will be challenged legally, because for those physicians who do not support this, by documenting it, they're making the first request. And so there is question of whether that will stand up legally or whether that will be contested. There's no specific language that's needed to make a request. So for physicians who aren't familiar with this can be kind of difficult. Patients will say many things like, I just don't want to be alive anymore. Is there anything we can do? Or is there anything you can give me? Or sometimes it almost sounds like a joke, you know? So it's becoming more comfortable with the way people ask the questions and being open to having a conversation with people. In this law, MDs are not required to refer a patient to a participating physician if they are not willing to participate. And so this still seems like it's a challenge because many patients have a difficult time finding a physician who will prescribe the medication for them. And then finally, what I mentioned before, each healthcare entity is now required to post on their website their current policy governing aid in dying. What the law doesn't say is what that, how that policy should be worded or what it should look like. In talking to many hospices who have official internal policies about this, we will not be posting our internal policy, but we will instead be posting a statement that says that we are an educate and support hospice and we support patients choosing this option. So there's lots of different wording, and if it would be helpful for anyone to see the examples that we'll be putting on our website, we're happy to share those. So as I mentioned, the final attestation form will be eliminated. This was seen as having really not much benefit. It didn't have to be turned in to the state, but it was the final attestation right before a patient was planning to ingest that they sign off and say they understand what they're doing. They're making this decision freely. Some doctors like this because it was that kind of final confirmation that they were making this decision on their own will, but that has been removed. And the last thing is that End-of-Life Option Act medications can be ingested within a healthcare facility. And this came about, the way it's actually stated is that the ingestion can be done in public. And that might sound a little scary, but 95% of people choose to do this in their own home. For those who wanted to take the medication in a facility, it wasn't clear before whether that was allowed actually by law. And so while healthcare facilities have the choice to either support or not support, those who do support, a patient can make this, can take the medication they can ingest in a healthcare facility. So the impact on our community, so each healthcare entity must post their current policy governing this End of Life Option Act by January 2022. There are still limited physicians in our community who will act as the attending physician and prescribe, and that often causes stress for some of our patients. We have a couple of physicians that we work with closely who are outside of our community who will prescribe, but it is challenging for patients to find a doctor who will do this. We are considering whether we would become a prescribing physician in the future. If we do that, we would not be able to be the consulting physician, right? We wouldn't be the two doctors who are choosing this. So we're really still looking at that closely. And then a really good resource for clinicians is the American Clinicians Academy for Medical Aid in Dying. That was started by Lonnie Shovelson. He was one of the first physicians in California to prescribe medication, and he prescribed for a majority of patients throughout California in the first few years as doctors were becoming more familiar with this. He stepped out of that role, and he stepped out of that role primarily because he wants to see other physicians stepping up and doing this and making this available to patients who want it. So I thought I'd just share a story at the end here, because I think I've learned a lot, and our staff have learned a lot about the patients who choose this. We had a patient last year who lived on his own. He had cancer. He had a neighbor who checked in on him regularly, who paid his bills, who took care of all of his paperwork and affairs. And they worked really closely together. What he was not willing to do is, when it came to a point where he wasn't able to physically care for himself, physically care for his own body, he wanted to ingest the medications. And so this was planned. He asked for our staff to be there. We said we would, of course, be there. It was planned for a Thursday afternoon. And Tuesday of that week, he called us and said, I looked at the weather report and it's going to rain on Thursday, and I want to experience the rain one more time. And we said, of course. And he experienced the rain showers. He lived for another couple of weeks, and then he said he was ready, and he made the decision. And what that really showed to me is these aren't patients who want to die. They want to live, but they are going to die, and they want to die on their own terms. And so we are committed to supporting patients. Our vision is that everyone in our community can live and die with dignity. And for us, giving somebody the option to make that choice and support them in that is a dignified life and a dignified death. So I think there's just one last slide if there are any questions, but also that we're here to support patients, but also to support any physicians in our community who may have questions about this or need support with a patient, or if there's a patient that comes to you and asks about it and you feel like you don't have the language, please feel free to reach out to us. You can reach out to me. I can put you in touch with our physicians, and we want to support in any way we can.
Thank you, Kathy. I'll just acknowledge that I was really moved by the story that you told at the end, connecting us with kind of the meaning of this work, and appreciate how thorough and clear the update was. kind of help us understand what the requirements are and how the regulation is being approached and what our obligations are as healthcare partners in the delivery system, but then bringing it back to what it means for the individual who has the opportunity to make that decision for themselves. So thank you for that. And I'll see if there are others that have questions or comments for Kathy. You can either unmute yourself or raise your hand, looking at the participant list and the chat. And I'm not seeing any.
Stephanie, I'll ask a quick question. Kathy,
Sure.
I know that there's been, like you mentioned, local advocacy around improvements to this bill. And I'm wondering, are there other areas that you see for improvement going forward? Do you feel like these updates address those issues, or where do you see this legislation evolving over time?
Yeah, I think that's a great question. Two things. I think still the shortage of physicians who feel comfortable, being the prescribing or the consulting physician. I think that's very difficult, and that causes stress for patients. What can also be stressful is that sometimes the medications are expensive, right? And it can be difficult to obtain the medications. So I think those are two areas that there's opportunity for work. I think also in around the, we'll see what happens here with now physicians have to document that first request, even if they are not involved with the practice. We'll see how that goes, because it's potential that will be contested, right? So, and then the other thing that SB 380 hoped to make this a permanent law, and that did not happen. And so I think the law now runs through 2031. So it will come up again, and I think it'll be interesting to see where we go in the next 10 years on our thinking around this and supporting patients in this way. But I do know that the folks at Compassion and Choices were really felt good about the work that they did and the work around that 15-day waiting period being eliminated.
Thank you very much for that, Kathy. And I'll just mention that HIP will be following up from this presentation with some resources, additional materials. I know that there's, I think, some training or further information that's being made available by Compassionate Choices. So we'll be sharing that in our follow-up email. Thank you so much for your presentation, Kathy.
You're welcome.
Okay. Well, last on our item is just to close, unless there are additional partner announcements that came up or anyone during the presentation. So are there any other partner announcements that we didn't catch at the beginning? Okay, and so I'll just check in with Elisa and see, do you have anything to share?
Only to wish everyone happy holidays. Thank you so much for a productive year, for all your support to the Health Improvement Partnership. I wanted to also make sure everyone was aware that HIP will be taking a wellness break over, let's see, we will close on the 24th of December and we will reopen on January 3rd. And that will be reflected in out of office emails. So in case you forget or you're trying to get a hold of a HIP staff member, you'll be reminded in out of office communication. So thank you all again. Happy holidays. Please stay safe and please take some time to be with family and friends.
Thank you, Elisa. And I think with that, we are adjourned. Thank you, everybody. Have a good day.
Thank you, Stephanie.
Thank you.